Okay, if everybody will get out your notes, we will start the lecture today. I'm sorry that I don't have video, but um, anyways, we just don't. So we'll go through death and dying, and then that'll be it for today. And then we'll get through pain uh, later on this week. I know that you guys have done this self study, and I hope that you guys kind of, I don't know, sometimes death is really hard to think about, and I think that I don't know. I think that it's good for us to know what we think about it, what our fears are, what our worries are about it, because especially in healthcare, death is something that you end up dealing with. It doesn't matter what area of healthcare you are in, like you're going to deal with death at some point, and you really need to be prepared for it and think about how you'll respond. What are some concerns you may have? What are some issues you think you may have? What is that? And so, and work through those and figure out what your concerns are and what your fears are. Because they happen. I mean, my first week of working at Children's, there was a little boy that died, and it was, I don't know, you just deal with some strange feelings. But anyway, um, so we'll get started. It says there's several works on people's reactions to death and dying. So, and it's just talking about theories. Now, Elizabeth Kubler-Ross is probably the most well known, the most well known theorist on death and dying. Really interesting. Her work is entitled On Death and Dying. That's the name of it. And this while I'm going, might as well. Anyway, she identified 5 stages of emotions that people go through during the dying process. Now, people don't have to go through these in a certain order, and they can go between and go back and forth and whatnot, and they may just experience 1 or 2 of them. But the first one is denial, and you guys will hear that denial is something, I don't know, you'll hear, no, this can't happen to me. I'm too good of a person. I've never done this. I've never done that, and so forth. Anger is another one. So why would this happen to me? I don't deserve this. Like bargaining, and you'll hear people say this a lot. Bargaining. Oh, if I can just, I'm good with dying. I just want to wait until after my daughter gets married, or what if I'll give all my money away and then maybe I won't die. Try to bargain out of it. Depression. So just a really recognition that it is them, but at the same time, just a sadness that it's really happening. And then acceptance um, is just a stage where they finally kind of come to terms with it. They know that it's going to happen. They accept it. It doesn't mean that they're happy with it. Um, it just means that they're dealing with it. And there's some different things that people do when they're in the acceptance phase, like call all their loved ones and talk to them. They set up maybe they're working on their will. Those are ways to know that people are kind of moving to that acceptance stage. Excuse me, I can't quit yawning. It says fear is often an element when an individual encounters the prospect of death and dying, and this is for both the person and the worker. So some things that people go through. It's really important to have these in mind if you're working with someone who is terminal, because they know they're terminal, and they're terminal, and it's just kind of Sometimes it can be kind of that white elephant in the room, like everybody knows it, but nobody wants to talk about it. And and a lot of times for people, their family doesn't want to talk about it. Maybe their family is in denial, or their family is depressed about it, but the person may have accepted it. And so sometimes they need someone to talk to besides their family. Emotionally and physically based reasons that people might fear death. So let's look at these. One is a fear of helplessness. So there's just nothing that they can do about it, and that's something that they worry about. Two is a fear of dependence on other people. So that's a big one. That's a big one for anybody, even if they're not necessarily terminal or close to being terminal. People, as they get older, that is something, a fear that lots of people have, is just having to depend on others to work or get things done. Fear of physical faculties. So just a fear of not being able to do what they used to could do, or fear of, you know, someone else having to help them go to the bathroom, someone else having to wipe them or change their catheter or whatever. Fear of mutilation by surgery or disease. So the fear of, like, what am I going to look like at the end of this? What is this going to do to me? So forth. Uncontrollable pain. Everybody has a right to have their pain controlled, in as they experience illness and death. And that's something we'll talk about it later this week, but you'll hear the word palliative care, and palliative care is that pain control. That's palliative care is often what people get on hospice. So they don't really get true treatment anymore that's going to make the disease better. They just get palliative care. It actually helps just control pain. And then the fear of being unprepared for death. So just that they're not ready. Maybe their estate isn't in order, or they haven't they have some regrets, or they have people that they need to talk to. Socially based reasons that people might fear death. Being separated from their family or their home. And then this fear of leaving things behind, kind of like with being unprepared. So just that they're leaving things behind for other people to do. And thinking about death, even for myself, death wasn't something I was so concerned about, because I knew what was going to happen to me after I died, and I still know where I'm going after I die. But at the same time, it was just me, and I thought, okay, if I die, then that's okay. But now in my life, I have two babies, and that changes your perspective a little bit, especially to think about that fear of leaving behind responsibilities, and fear of leaving behind kids changes my perspective on death than what I used to. Still not worried about what's going to happen to me after I die, but what would happen to my family. Interventions that you can offer as a healthcare worker. So just talk about things. Be willing to listen and talk, because again, they may not have anybody else who is willing to listen to their family. Their family may still be in denial, or maybe maybe they don't want to talk about it, or they're depressed about it. Avoid superficial answers like it's God's will, or this is, we're born and then we die, or whatever. There are some serious superficial answers that don't help anybody. It's very cliche. We talked about non-therapeutic communication, things that are very cliche. And that is an example. I'm not saying that it's not God's will for them to die, but I am saying that doesn't, just saying that doesn't help anybody deal with it. Just leaving it at that. Now you can have, it says provide religious support as appropriate, and that's it. And it's important. People believe different things, and I don't know, that it can get, you may feel the need to share what you believe, and I think that's fine. But at the end of the day, um, you can't make them believe what you believe. And as a healthcare worker, you're there for them. You may tell them what you believe, and you may want to share your ideas and thoughts. And I think that's good. I think that we should do that. But at the same time, again, at the end of the day, they're the one who's dying, and we have to provide support regardless of what decisions they make or don't make. And I hope that makes sense. Um, so stay with the patient as needed. So just being with them is a big part of it. And then work with the families so that they can also offer support. Physiology of dying. So now we're just talking about the physical aspect of it. The somatic death is the death of the body. It involves irreversible events that leads to cell destruction and death. So just the process of death, physical death. Causes of death vary, but there's lots of changes that occur in each event that causes that. So all the vital systems, of course, have to die in order for actual death to occur. So respiratory, you think about the things that have to occur for us to live. Basically, we have to be breathing, and our heart has to be beating for our body to continue working, our cells continuing to function, and so forth. So those are the main ones we'll look at. And then we have brain death, of course, too. So respiratory systems, they can no longer, give our body the oxygen that it needs. It says respirations become stridorous or noisy, leading to what's called the death rattle. And stridorous is just a really loud breathing, rattly breathing. Usually stridor, when you hear it in the large airways, so like the trachea. You might hear it in the bronchi, but Cheyne-Stokes, these are the end of life breathing. So when you see that word Cheyne-Stokes, that's what you think of. That's the end of life. They're in the very last stages, close to death. They show that their respiratory system is failing. Says it consists of alternate hyperopnic and then apneic phases. And if you guys remember, that hyperopnic would just be really, really fast breathing, and then apneic would be not breathing. So they have periods of breathing fast and then not breathing, breathing fast and then not breathing. Let's see. These phases alter the concentration of carbon dioxide, so they actually reduce the level because they're breathing out. Okay, so that those hyperopnic episodes, they would be breathing out faster than they'd be breathing in. And then it says sensors within the body prevent the body from breathing in order to increase the level of carbon dioxide. Let's see. That's why they would have the apneic episodes, I'm sorry. But they're never really able to reach an adequate balance. So in the end, they will quit breathing. I know we think we breathe out carbon dioxide and it's waste, and that's the case. That is true. But we still have to have a certain level of carbon dioxide in our body for it to function. There's specific levels. And whenever you guys get, if you go to take an anatomy, whenever you get to college, or any of you nursing students taking your first pathophysiology class, y'all will talk about the acid-base balance, which is a really difficult chapter in any patho class. And it's hard because, I don't know, there's just a lot to it. And that's where carbon dioxide has to do with the acid-base balance in your blood, your pH levels, and so forth. Okay, so cardiovascular. The heart, says, is unable to pump strongly enough to actually keep blood moving you'll remember, your heart has to pump strong enough, our heart's pump strong enough to actually shoot blood like 30 feet into the air. And think about all the blood vessels we have running through our body. The heart has to be able to pump blood through those. Excuse me. So if it's getting weaker and weaker, it's not efficiently able to do that. So it says blood backs up through the heart. Ultimately, it backs up into the lungs and the liver, and this causes congestion. When we talked about congestive heart failure, of course, that's a chronic thing. This is like really during death. Decreased blood causes decreased circulation to the body. And one of the things that happens is that blood shunts to the vital organs: liver, lungs, brain, heart, blood. So our arms and legs actually lose blood supply at the very, very end because all that, the heart is just not strong enough to get it everywhere. So blood shunts to those organs that our body really needs to survive. So skin becomes cool to the touch and very pale. So sometimes it can even look gray, or people will get like a mottled look. And mottled look is like a kind of a spotted look. It says in dark skinned people, perfusion and oxygenation of the body is determined by mucous membranes. So the darker the skin, sometimes you can't tell. So their mucous membranes, you can pull down their lower eyelids and look there, or maybe look in their mouth. But usually lower the eyelids, if you just pull them down, they should look nice and pink and red. But if they look really pale, like white or gray, that's a sign. It says failure of peripheral circulation frequently results in a drenching sweat to cool the body surface. Pulse becomes weak and thready. Hopefully you guys remember that word thready. That's just like a very faint pulse, and it will get irregular as time goes. So it's a stronger pulse will mean death is hours away, but a weak irregular pulse means that it's getting pretty close. You may even have to listen to an apical pulse. That's the one at the chest. Metabolism rates decrease when the cardiovascular system fails. They can, as far as going to the bathroom, they can either retain it or they might become incontinent, and they may just soil themselves. Could go either way. Urinary output, their kidneys will fail, so they're not going to be making urine. Neurologic function decreases because they don't have as much oxygen to their brain. So lose sensation, lose the ability to move. Reflexes is something that they'll lose. Reflexes is something that they would look at like at the hospital or something. Do they have the reflexes? No, they've already lost those. Says dying person tends to turn towards light as their sight goes out, and they'll hear only what is distinctly spoken, or maybe even spoken to them. They won't hear like a rumble of noise. And touch sensation diminished, but pressure remains. They can remain conscious or become unconscious. I would say most of the time people become unconscious at some point. And that can be for hours, or it can even be for a couple days. I always think, I had this one patient in home health, and every time we talk about this lecture every year, I think about her because her family didn't want her to go to hospice because they really liked the lady who our home health aide that came to see her, and they just liked the nurses, so they didn't want to switch. And I just remember going over there, I went over there a couple days, maybe the day, or maybe the day before she died or the day she died, and she was already unconscious. And I just remember going, and I prayed with the family, and it was just I don't know, it was a very like peaceful experience, but at the same time, it's just very, I don't know, I don't even know how to describe it, but it really helped my thoughts on death and my idea of what death looks like in the end, but she was unconscious for a couple of days. She had a lot of hematomas too, and a hematoma, is just a blood. It literally means like a blood mass, but you could see because her blood had pooled underneath her, so like all the back of her legs and calves there was like blood, like pools of blood, and you could see, and they were just full, and that was just part of that decreased circulation. It's part of her process of dying. Pupils might be sluggishly reactive. Another thing that she did, she was really confused right before she went unconscious. I mean, she was talking to people in the room. She was, seeing things and so forth. Pain might be present, but you don't ever withhold it. It doesn't matter if you think that they can feel it or not, or if they're confused or not. Like, they may be experiencing pain but not know how to say it. If unconscious or unable to talk, assess for restlessness. So, are they moving? Are they in a fetal position? Are they guarding areas? Watch their facial expressions, and then any kind of tightness of muscles. So, like I said, if they're guarding or they have their arms up or their fetal position. And the physiological aspect. So, criteria for death. This can be kind of a sticky situation, but typically the hospital has a policy on what they determine is dead. So one can be pronounced dead at the hospital and maybe alive in another one, depending on what criteria they use. Usually, it says most widely accepted criteria is a flat electroencephalogram, meaning that brain death has occurred. So that means they hook up electrodes to their brain and there's absolutely no activity. That means that brain death has occurred. As the heart, lungs, and the brain form the trinity on which the standards for irreversible death are established. So as absence of respirations, absence of a heartbeat, and then the flat electroencephalogram. Excuse me, my throat. When the above signs are present, along with the absence of pupillary reflexes, that means their eyes. Pupillary reflexes are when you shine light in your eyes and your pupils get larger or smaller. Or if they're cornea, that's the clear part of the eye in the very front, clouds over. Any absence of movement, then we know, of course, that death has occurred. And I don't know if you guys know this, but at home, a doctor doesn't have to declare death. And the justice of the peace actually can come in and declare that death has occurred. So, the study of death is known as thanatology. So studies show that clinical death is not the same as biological death. For example, after clinical death, the hair continues to grow for several hours. The liver is still converting glycogen to glucose, and the muscles contract. That's what causes the rigor mortis. So, kind of interesting to know. I always think this makes me think of CSI. I watch that. I don't always have like that show. I've watched it. I've always watched it. And thinking about, they can tell how long it's been since they died according to liver temperature and then the rigor mortis, if it's set in or not. It says it usually begins about 2 hours after death, and then the muscles remain contracted for about 30 hours. Healthy muscle contraction works in such a way that the nervous system tells the muscle to contract, says that calcium channels are open in the muscle and calcium ions move into it. That makes it shorten or contract. And then whenever it relaxes, then it gets rid of the calcium. And so it says this happens in one of two ways. The calcium is stored in the sarcoplasmic reticulum. That's just, sarco is always, you'll hear that word for muscle. So that's kind of like the endoplasmic reticulum that we've talked about in the same idea. It's just this one's in muscles. And then calcium can be pumped back through the channel, so it just leaves the muscle. But in death, it can't. That movement doesn't occur. All that calcium stays in there. And we know what happens. Okay, for example, calcium, even in the bones, calcium makes them really strong, hardens them. So same idea with the muscles. Says this causes muscles to contract and stiffen, and then the entire body stiffens. That's rigor mortis. So, anyways, that's it as far as this goes. Kind of a lot of physiological aspects of it. I hope that you guys, after you do the self-study, or after you did the self-study, you discussed it. If not, you don't have to. If you have something that's you don't want to share, whatever, that's fine. But that's okay. You don't have to share everything. I just want you guys to talk through some thoughts and ideas that you have on death. What are some things that maybe you struggle with? What are some things that you find easier? Have you dealt with it before? Have you, what are some things that you've experienced as you dealt with death in your family? What are some things that helped? What are some things that didn't help? Talk about those so that you guys can be better equipped to answer questions or help people deal with it. It's an important aspect of healthcare that you're able to talk about death, help people get through it, is because that's part of it. That's part of something that you'll be required to do. Anyways, I hope you guys have a good day, and I will see you soon.